Hello everyone, I hope you all are doing good. I am in a great health, alhamdulillah, and I am gonna be discussing these concepts with you guys because I've been studying for my step 2 exam, and I feel like sometimes when you're starting we need a soft start, so I'm making this channel for that, or any other international exam that you're gonna give, or if you want to revise your concepts that you have been studying from different resources for USMLE step 2. So today we'll be discussing this very important concept, ectopic pregnancy. You have a suspected ectopic pregnancy. The patient comes to you with vaginal bleeding. There's due to beta HCG is positive, and there's lower abdominal pain. And then you do ultrasound, and you do not see a fetal pole, or you do not see any adnexal masses or anything. So you're like, oh my god, this patient has positive urine beta HCG but no fetal pole. So maybe this is ectopic pregnancy, but you do not know if it is for sure, because in some cases you do not see the fetal pole until the fetal pole or the embryo is a certain age. So what you do in this case is, this is a very high yield topic, okay? What you do is you're going to see if the patient is hemodynamically unstable or hemodynamically stable. Hemodynamically unstable means the patient has a lot of bleeding and then the patient is going into shock. So what you do is you go directly for surgical consultation. You do not wait to confirm if the patient has ectopic pregnancy or normal pregnancy. So after that, when the patient is hemodynamically stable, what we do is we have three cases. Okay, we do like transvaginal ultrasound. I'm gonna change the color. So we're gonna do transvaginal ultrasound. If you on transvaginal ultrasound see an adnexal mass, adnexal means fallopian tube and the ovaries, right? So if there's a mass there and then you have beta HCG, it means the pregnancy is either in the fallopian tubes or in the ovary that you're going to see on the ultrasound. So you're going to give methotrexate, which is the treatment for ectopic pregnancy. Now in the other case scenario, which is the best case scenario, you're going to do you're going to see uterine pregnancy. In that case, you know that this is the fetal pole. You see the fetal pole, so you're going to just let it go forward because this is a known pregnancy. But in case when it is known diagnostic that we are concerned with, what you do is you look at the beta HCG levels. Okay, so if the beta HCG level at this point in pregnancy is more than 3500 international units, then what you do is in the next consultation, which is after 2 days, you repeat the beta HCG and transvaginal ultrasound, because if it's more than 3500, then it is past the time. Why 3500? Because this is the threshold where you can see the fetal pole. So if it's more than 3500 already and you cannot see the pole in transvaginal ultrasound, it's non-diagnostic, then you wait 2 days and then you're going to see the fetal pole again in 2 days on transvaginal ultrasound, and you're going to repeat the beta HCG. And in the repeat beta HCG levels, what you have is like you have a 35% increase in HCG level. Okay, so if 35% of the 35,000 is like 4,000 something, right? If the ultrasound in beta HCG in 2 days is that, then it means you have a pregnancy, a viable pregnancy that's gonna go on to become the fetus, and the person's gonna have a normal baby. But then normal pregnancy, and then if you do not have like the 35 pregnant increase, or you do not see the fetal pole, it means it's ectopic pregnancy or it's a non-viable pregnancy, because the 35% increase is not happening. Okay, so in that case, what you do is you go for this is very important, you go for dilation and curettage. In this case, if there's no 35% increase in the beta HCG, then you go for dilation and curettage and you see the endometrial contents. If the endometrial contents does not contain chorionic villi and chorion and the trophoblastic cells, then not chorion but chorionic content, which is like the trophoblastic cells, then what you do is this is a ectopic pregnancy. Okay, so you give methotrexate. If you see these trophoblastic cells, trophoblastic components, then you know that there was a pregnancy. Maybe it was non-viable, so it just terminated on its own. So you're gonna do nothing more because you already did dilation and curettage. After that, we have the less than 3500 mark. In this case, you only repeat the beta HCG because you might not see the TVUS, fetal pole on transvaginal ultrasound because it's still so early. You might not see it. But if you repeat beta HCG and then in 2 days you do not have the expectant increase of like 35%, then you're gonna be like, in 24 hours you have 35%, right? So you're going to be like, okay, so this is not a viable pregnancy, or maybe it's ectopic pregnancy, because in ectopic pregnancy we also do not have like the accurate increase in beta HCG. So you're going to go under the same process. If there's no increase, you're going to do DNC, see the contents, and if the contents have the components, then trophoblastic component, just let it go. If they do not have, give methotrexate, or you can go for surgery. So this is the protocol, what you do for suspected ectopic pregnancy. Yeah, it is 35%. I think I said 35% in 24 hours. No, it's 35% increase in 48 hours. Pardon me for that. So this is all about this video. Hope to see you in next video. Take care.